including the alpha interferon, the interleukin 4, interleukin 10, and the gamma interferon. So, according to this model, there is strong innate immunity elicited by the chikungunya virus, and this immunity produce abundant pro-inflammatory markers like alpha interferon, interleukin 4, interleukin 10, and gamma interferon. So this is the second model proposed for the pathophysiology of the chikungunya fever. The flow cytometric study. The flow cytometric study of the chikungunya virus and chikungunya fever has demonstrated that in the previous part of the fever there is CD8 plus lymphocyte predominant response, and in the later part of disease there is CD8 plus CD4 plus lymphocyte response. But more interestingly, there is CD93 plus mediated or based apoptosis. This CD93 mediated or based apoptosis of CD4 lymphocytes in later part of the disease explains the lymphopenia in the chikungunya fever. Why there is lymphopenia in patients of chikungunya? Because there is CD93 based apoptosis of CD4 lymphocytes in the later part of the disease. The diagnosis of the chikungunya fever. The chikungunya fever is diagnosed on the basis of some different criteria like the history taking. There should be proper history taking. High grade fever more than 39 degrees centigrade or ranging from 100 to 205 degrees Fahrenheit. More than 39 degrees centigrade, 102 to 105 degrees Fahrenheit, and incubation period of the chikungunya infection is 3 to 7 days. But if you want to increase the range, it may be 1 to 12 days. There is phase of high grade fever which range from 2 to 5 days. 2 to 5 days. Abrupt onset of the high grade fever. Fever subside to normal after 2 to 5 days, and there is period of non-febrile period for 8 to 10 days, and the fever reappear for 2 to 3 days. This is known as saddle back phenomena, and it is also seen in the dengue fever. So there is 3 to 7 days incubation period. Range may be from 1 to 12 days. High grade fever, joint pain, especially the small joints of hand, that is interphalangeal joints, metacarpophalangeal joint, carpometacarpal joints, and wrist joint, that is joint formed between the radius and scaphoid lunate bones. Ankle joint is also involved, and joints may be swollen, maybe tenosynovitis. The arthritis in chikungunya is polyarthritis and migratory arthritis. So arthritis is polyarthritis. More than 10 joints are involved, and this is migratory type of arthritis. So high grade fever from 102 to 105 degree, or maybe 39 degree or more centigrade. Incubation period, there is 2 to 5 days history of high grade fever with joint pain and morning stiffness, which improve with the physical activities. And there are some other features like some prodromal features, sore throat, pharyngitis, headache, and the cutaneous manifestations of the chikungunya virus. Initially, there are the flushing of the face and the trunk, and sometimes also flushing on the flexure parts of the upper and lower limbs. As the time passes, these flushing lesions are converted in diffuse erythematous maculopapular rashes. Diffuse erythematous maculopapular rashes. These lesions fades, and there may be some other types of lesions like xerosis, urticaria, and patches on the skin. There may be some rare neurological complications also, like the encephalitis, which is demyelinating type of encephalitis, Guillain-Barré syndrome, which is ascending type of symmetrical paralysis due to demyelination of the neurons in the peripheral nervous system. There may be multiple sclerosis also, but these are very, very rare complications of the chikungunya virus infection. There may be myelitis also. But the diagnosis is made on the basis of different criteria. One of them is history taking, the other is the lab diagnosis, but the cases of chikungunya are divided in three types: probable cases, suspected cases, and the confirmed cases. So there are probable cases of the chikungunya, suspected and confirmed. If a patient is having a history of high-grade fever with joint pains, with rashes, typical rashes of chikungunya or viral fever, and also having the stooped over posture, these are the suspected cases. But when the patient is having all signs and symptoms of the suspected case plus travel history, and the dengue and malaria have been excluded dengue and malaria or other viral and bacterial infections. These cases are known as probable cases. The confirmed cases of chikungunya are the patients who are having all signs and symptoms of the probable and suspected cases, and the detection of virus in blood, detection of virus in blood in early phase of disease, that is within 5 to 7 days, serological detection of the virus. The other criteria is the detection of the antibodies, serological antibodies, the virus specific IgM detection, and fourfold or more increase in the IgG antibodies, the detection of the RNA of the virus, the genetic detection of the virus using the reverse transcriptase, PCR, polymerase chain reaction. Besides these criteria, there may be lymphopenia. Hemorrhagic episodes are not seen generally with the chikungunya. These are very, very common with the dengue infection. So, thrombocytopenia may be seen, or the thrombocyte count may be normal. Penia may be present or absent. Neutropenia, which is well seen in the dengue infection, may be present or absent in chikungunya. Hemoconcentration and shock are rarely seen in chikungunya infection. These are common in dengue infection and dengue hemorrhagic fever and dengue shock syndrome. So these are the different criteria for the diagnosis of the chikungunya, but the stooped over posture and history of high-grade fever and typical rashes of chikungunya are the best diagnostic criteria for the chikungunya fever and chikungunya arthritis. The treatment of chikungunya treatment is having two parts. One is the drug part and other the physiotherapical part. And the third is the supportive treatment.